The Intercollegiate
Psychedelics
Network.
Hi, everyone. Thank you for having me here today. My name is Shaili Patel. I am a medical student at UC Irvine, and I just completed my Master's of Public Health at UC Berkeley. And I am excited to talk today about the therapeutic potential of psychedelics in postpartum and miscarriage-related depression. So when we think of psychedelics, we have heard of numerous conditions that psychedelics have been used for. The well-known trials for MDMA and PTSD have been documented. Psilocybin is being used for depression as well as existential life distress, as well as coping with traumatic losses. However, we don't hear very much about its implications in maternity-related events. And it is understandable that there is some caution in using new drugs with pregnant patients as well as lactating patients. However, it is really important to consider the needs of pregnant and breastfeeding patients because they are an essential part of our community and their mental health is incredibly important and unique. For some context, 1.29% of clinical trials in the United States include pregnant women. It's a very small number, even though 90% of women take at least one medication after or during pregnancy. We've also seen that women of childbearing age face significant barriers to participating in phase 1 and phase 2 clinical trials, which means that there's very little data on safety and efficacy of drugs in their initial stages in this population. This is incredibly important because this pharmacologic vigilance around maternity and breastfeeding leads to this population being the last to receive new treatments, being under-prioritized in clinical design, and oftentimes their experience being rendered invisible. There is a really important reason that there is a pharmacologic vigilance around this group because in the 1940s and 60s, drugs like DES as well as thalidomide had caused birth defects and issues. However, it's important to think critically, but also think critically about how to better support these populations in including them in clinical trials and considering their needs, as well as keeping them safe. So the next set of this part of this presentation will talk about postpartum depression as well as miscarriage-related depression and the potential use of psychedelic-assisted psychotherapy for these conditions. I just want to, before I start talking about this, state that all of this is an independently conducted literature review and suggestions. They aren't medical recommendations. And the goal of this presentation is to call for better inclusion, accessibility, and prioritization of mothers and their needs in research. And it's not, and so with that, let's talk a little bit more about these two conditions and the mother's journey. When we talk about a mother's journey, it goes through many different phases. Before becoming pregnant, the individual has their own identity, their own relationships, has to only manage their own health and their own responsibilities. However, after they become pregnant and conception comes into place, there are a lot of different stakes at play. Becoming pregnant is something that varies per individual. It can be difficult or easy. It can be intended or unintended. It can be a very emotional period with lots of different expectations from themselves and from others. Gestation, which is the period of pregnancy, it lasts about 40 weeks. It's about 3 trimesters long, and there are numerous physical and emotional changes that a mother goes through across all of their body systems, as well as because of the new responsibilities and load placed on them as no longer just an individual, but an individual who is growing potentially another individual. At the end of this period, or sometimes in between, there is normally a high stress event, which is either a miscarriage or a delivery. Both of them have somewhat predictable but uncertain outcomes. And because of societal pressure, a lot of the emphasis goes on to the mother's role in this state, putting a lot of pressure and blame and um, you know benefit and other things on the mother. And especially when it is a miscarriage, this is something that is not talked about openly. And it's often, there's a culture of silence that prevents us from talking about this. And after a miscarriage or delivery, there is typically a postpartum stage, which is where a mother needs to adjust to a new identity, whether it be taking care of an infant, having to breastfeed every 4 hours, or having to cope with loss, hoping to bring another individual into the world, but having to deal with the fact that this is not something that came to fruition. And so, taking this into consideration, pregnancy is a very thin line between life and death. When we see this picture, some people are filled with hope and joy. Some people are filled with a little worry, but it is a picture that instills a lot of emotion. And entering pregnancy is a time period where um, it's unclear where the line between the mother identifying the fetus as part of herself or as a separate individual occurs. And because of this, when a miscarriage occurs, it is hard to go. It is a very complicated process because there's a grieving of potentially oneself, a grieving of a life that could have come, and there are no real rituals or things in place to mourn that loss. And this is especially important because 10 to 20% of known pregnancies end in miscarriage. The actual number is probably much higher at 30% because many pregnancies end before someone is even aware that they are pregnant. And it's been seen that individuals who undergo a miscarriage have 2.5 times the level of depression, anxiety, and obsessive compulsive disorder, even at 6 months after the loss. And this is something that affects, subsequent pregnancies, impacts their interpersonal relationships and their overall health. And suicide risk is 3 times higher in individuals who, had faced a miscarriage as opposed to those who didn't. This is extremely important, and it is something that is not openly talked about. And it is an untold story of the mothers in our lives. This is a picture of me when I was very, very little and very sassy. And this is my mom. But my mom has two loving children now. But between me and my younger sister, she had a miscarriage. It was something that, she was very far along in her pregnancy. We all had hopes. And when this happened, it was an extremely stressful event. We didn't talk about it too openly afterwards, but she was grieving and she was stressed. And, while she made it through and she supported us, it did take a toll on her, and it does take a toll on a lot of mothers. And these stories and these conditions should not be something that we keep in silence. It should be something that we think about proactively and think about how we can better support them. So in addition to miscarriage, postpartum depression is also something that's very prevalent. It affects 1 in 5 mothers, and less than 15% of them receive any treatment. Postpartum depression makes individuals more likely to miss appointments or vaccinations. It decreases their rate of breastfeeding, impairs the bond between mother and child. And it also impacts the cognitive and affective development of an infant. And this is something that is compounded when an individual has a young maternal age, has a lack of support, a lower socioeconomic status, a history of mental illness, substance use, or a difficult breastfeeding or birth experience. I talk about these two time periods, postpartum depression as well as miscarriage and miscarriage-related depression, because I really want to focus on how we can be more inclusive of the needs of mothers while recognizing the safety considerations as we expand the reach of psychedelic-assisted psychotherapy. The current treatments for postpartum depression particularly include these 3 treatments. Selective serotonin uptake inhibitors, or SSRIs, are normally the first-line treatment. They're covered by insurance, but they take 4 to 6 weeks for effect and don't have very much evidence of benefit in postpartum depression. Interpersonal therapy is also first-line treatment, but it has variable insurance coverage, takes a long time, and does have a good amount of benefit. And the most effective treatment, brexanolone, is very costly and is only offered to patients after they fail other treatments. And it takes much longer. It's a 60-hour IV infusion, which requires separation between mother and baby or mother and family for a longer period of time. And while it has benefit, is something that takes much longer and much costlier and has a barrier to entry. And so in this context, I wanted to talk about psychedelic assisted psychotherapy and how it's been used for major depressive disorder, and talk about how there might be a potential to conduct clinical trials or consider the needs of individuals facing postpartum depression as well as miscarriage related depression in this context. When we look at postpartum depression, there is a great deal of overlap with major depression. There are similar risk factors, as you can see here, like financial problems, lack of support, substance use, chronic illness, family history. But postpartum depression also has unique risk factors like having a C-section or a preterm delivery or having gestational diabetes or having any type of birth complications or pregnancy complications. The outcomes of major depressive disorder and postpartum depression are also very similar, leading to isolation, change in productivity, like weight gain or loss, self-harm, suicide. But postpartum depression also impacts mother and infant bonding, infant development, and other factors. When we look at symptoms in terms of major depression, postpartum depression, there are a lot in common as well. There's changes in sleep, changes in appetite, interest, feelings of sadness, feelings of guilt, suicide and self-harm. There are some differences, but it's really important that we look at these similarities. But there are some important differences between major depression and postpartum depression in the brain that have been seen in some studies. And this may be something that could inform potential avenues for treatment. So one study showed that those with major depression had a heightened amygdala response to negative stimuli, while those with postpartum depression had a dampened amygdala response and corticolimbic activity. The amygdala is a part of our brain in the limbic system of our brain, which is considered the emotional system of our brain. And it's particularly important in fear as well as emotional responses. Although major depression and postpartum depression have similar symptoms on the surface level, this shows that there are differences happening within the brain that may be important to consider when considering how we go about treating them. Another study showed that in 2018 showed that psilocybin increased amygdala responses, which allowed depressed patients to work through their emotional response with psychological support. Given that psilocybin increases amygdala response and postpartum depression has a decreased amygdala response, it may be something that could have a hidden benefit in postpartum depression. However, it needs to be studied much more in detail. And when we looked at SSRIs, when SSRIs were studied, SSRIs typically cause a dampening effect of amygdala activity. And so because they decrease that emotional limbic system, this is hypothesized to be the reason why that they have more success in treating individuals with major depressive disorder as opposed to postpartum depression. Because in major depression, there's a heightened amygdala response that is calmed by this. While in postpartum depression, dampening an already dampened amygdala response would not be as effective. And so taking some of these studies into mind and taking everything also with a grain of salt and caution, I get to the next slide where I ask, is there a role for psilocybin? We know that psilocybin is a serotonin 5-HT2A agonist and works particularly also in the prefrontal cortex as opposed to simply the limbic system. It's shown to increase intercortical connections and reduce connections in the default mode network, which all contribute, which are all ways that have shown to be beneficial in aiding in depressive symptoms by helping reducing like ruminations and thoughts that contribute to depressive symptoms. But psilocybin has also been shown to increase amygdala sensitivity, which is something that differentiates postpartum depression from major depression, where postpartum depression has a decreased amygdala sensitivity and major depression has increased. And so while studies should be continued to be conducted to see how psilocybin can be used in postpartum, how it works in postpartum mothers or anyone in a postpartum state, this is something that could be particularly promising and valuable to study in clinical trial context in terms of using psilocybin or other psychedelics with psychedelic assisted psychotherapy for mothers in the postpartum depression or miscarriage depression related phase. There's currently no clinical research on psilocybin's resetting effect associated with postpartum depression, but it does warrant exploration of this topic because the prospect may be hopeful. And so in addition to this, it's really important to consider the limitations and safety concerns of psychedelic assisted psychotherapy. There are relevant concerns that there may be impacts on the body. Studies have shown that the elimination half-life for psilocybin is 3 hours, so that after 48 hours, 0.0016% remains in the bloodstream, and that it is virtually undetectable in urine after 24 hours. There's also the valid concern that the use of psilocybin or a psychedelic may be transmitted to an infant through breast milk if a mother is breastfeeding. It has been shown that in some studies that psilocybin can transiently increase prolactin during its peak effects, but levels return to baseline 5 hours after oral administration, and it leaves no effect on breast milk production afterwards. And prolactin is something that increases lactation, but given this, it's important to study this and look at how this affects milk production as well as transmission. Other studies have shown that psilocybin and psilocin, which is have both bind to albumin, and which suggests that they might be less likely to diffuse into breast milk. Other studies have also shown that psilocin is less acidic and less likely to pass into breast milk. However, it has a lower molecular weight and is more lipid soluble, so it could more readily cross into breast milk. These are all very important limitations and safety concerns to keep in mind when designing studies and ways to support this population. With all of this in mind, I wanted to share some ongoing work that has been done in the space. There is a pharmaceutical company called Field Trip Health that has recently received a patent for a synthetic prodrug called FT104, which is a synthetic serotonin 5H2A agonist. It has an active component very similar to psilocybin and has a very high bioavailability after administration. However, it is expected to have a shorter duration of activity, which is about 2 to 3 hours, so that it can clear the body much faster, and it's out of the system in 24 hours rather than 48 hours, and can allow mothers to breastfeed again. If you are interested in reading more about this and other things I've talked about, each of the slides have links at the bottom of them. And this is something that they have been working on, and they are expected to start some clinical trials soon. I bring these topics up, but it's insufficient to just talk about the science, but it's important to elucidate some of the experiences that patients have had. These are some quotes from a licensed marriage and family therapist talking about her patients, saying that when a patient began microdosing, she felt more uplifted and grounded in her body. Even though it was something against what a societal idea of a mother was supposed to be, it had benefited her. An anonymous submission with talking about an experience on LSD showed how someone after their miscarriage was able to reflect on their grief. This is just one snippet from a longer section where the individual says, I realize grief is something we choose to hold on to, because if we let it go, we let go of the remaining link to something that we have lost and loved. And so individuals have had benefit with this, and it is something that may be worth studying more in depth and with a more rigorous evaluation. With this, I come to some of the last slides in my presentation where I will propose some potential clinical trial and practitioner models. I propose these because pregnant as well as lactating and postpartum women are an underserved population in the mental health sphere. However, I understand that there are caveats and limitations of trying to design a trial with this population without considering the risks and the limitations and the potential safety concerns. But taking into consideration some of the literature I've looked at, if we were to look at treating postpartum and miscarriage-related depression, a similar model to how major depression is treated could be used, where an individual could undergo a 6-week-long session with 2 sessions of psychedelic-assisted psychotherapy, separated in time by 3 weeks. That could be paired with a form of psychotherapy. Acceptance and commitment therapy is a form of therapy that is used for miscarriage-related grief. And interpersonal therapy is something that has been shown to be effective for postpartum depression. And so pairing the psychedelic session with that type of therapy could be a treatment arm that could be used. And a control arm could potentially be the therapy alone plus or minus the standard of care, which is an SSRI. Given the risks associated with like lactation, as well as passing things on to an infant, potential clinical trials could start off by including mothers who are not breastfeeding due to choice or other reasons, that are facing either postpartum depression or miscarriage-related depression. The inclusion of this group, as opposed to breastfeeding women, would minimize any risks passed on to an infant, but would also still allow for this group that is often understudied to be offered treatments and to participate in these trials. Subsequent studies could work into including breastfeeding women by providing structural support. There are these groups called breast milk banks that typically provide breast milk to premature infants when a mother is unable to breastfeed initially. However, these breast milk banks could be something that individuals who are participating in studies could be offered donations from while they are undergoing a treatment. So while a compound clears their body, hypothetically being 48 hours, their breastfeeding infant could receive this structural support and allow for better inclusion of these individuals in these studies. Obviously, we have to consider potential risks of prolactin elevations, transmissions through breast milk, which all warrant further studies. And the changes in symptoms could be measured through the following scales for postnatal depression as well as the perinatal grief. And so with this all in mind, I just want to say that this is a call for better inclusion, accessibility, and prioritization of mothers in research. This is a very important population that supports the well-being of entire generations, and their mental health is incredibly important. And it's really important to understand the needs and how to better support them through this incredible journey of changing identity and changing roles in society. I do want to caution that this is not an encouragement to try psychedelics independently or in a non-medical or clinical trial context, and that all of this information shared is an independently conducted literature review, and it's not a medical recommendation. And so with that, I just want us to all think about the mothers that we have met in our lives, the stories they may have had, and how important it is to invest in them and to consider them when we talk about new treatments and these new treatments that are also coming out in the field of psychedelic assisted psychotherapy, as well as and beyond. Thank you again for your time, and I'll end you with this. Let's invest in the health of our bodies.